Hello and welcome to the Boston Structural Heart YouTube channel. My name is Feroz Mahmood, and today I will be discussing an advanced analysis of the tricuspid valve apparatus. This is somewhat poorly understood, somewhat controversial. That is the assessment of tricuspid annulus and leaflets, and in relations to what diameters or area and how do we see these leaflets. So I will try to keep this presentation very simple and at the same time try to make it more advanced, review the modern literature and what opinion leaders in different studies have demonstrated as relates to the tricuspid leaflets, annulus, and apparatus as a whole. These are my disclosures. I make educational materials for both GE ultrasound as well as for Abbott Medical Systems. Now, let's get to the point over here. As you can see, you might have noticed so far, the tricuspid valve generally has been treated as the Cinderella of heart valves. The tricuspid sessions are usually moderated and delivered by the junior-most faculty on the last day of a conference, generally after a lunch session where either half the people don't show up or are already asleep at that time. And the reason for this thing is that people have generally assumed that functional tricuspid regurgitation, which is the most complicated and most controversial thing to handle, is a consequence of left-sided disease, which means if you have a higher LA pressure, as you can see in this figure, and as the higher LA pressure leads to pulmonary hypertension, there's increased right ventricular afterload, leads to tricuspid annular dilation, functional tricuspid regurgitation, and that eventually leads to right ventricular remodeling and right ventricular dysfunction. So therefore, it was assumed that if you were to correct the left-sided disease, the tricuspid regurgitation would correct itself. So that was generally the assumption. However, that didn't happen, and people have found out that tricuspid regurgitation does not correct itself, tends to come back and has significant impact on the functional recovery of patients who undergo left-sided interventions without any intervention for functional tricuspid regurgitation. So in this presentation, we'll go over the structure of the tricuspid valve, which is the both leaflets and the annulus. Then we'll go over the function that specifically relates to remodeling, and we'll go over whether what to measure, the diameters of the tricuspid annulus or the area of the tricuspid annulus. And now that we can analyze the tricuspid annulus dynamically, what is more important? So let's go over the structure, and that first thing that we want to go over the structure is the leaflets. So the most important thing that we know over here is that we call it a tricuspid valve, however, as per the nomenclature, but there are three leaflets only about 54% of the patients. This is essentially a nomenclature because more than 50%, almost 50% of people have more than three leaflets, and the nomenclature of the leaflets is in relation to their correlation with the anatomical structures. For example, this is the septal leaflet that is referred to septum because it is right next to the interventricular septum. The anterior leaflet is situated more anteriorly with patient in the supine position and is closely related to the aortic valve, and that forms its basis of identification. And the third leaflet, which is more posterior, is referred to as the posterior leaflet. So that's essentially not in correlation to anatomy, but more so in relation to their structure. Relationship with the other valves is what determines their nomenclature. Now, the guidelines, however, are very rigid in defining the scan plane rotations and probe positions where you see the tricuspid valve. And these guidelines are based on this assumption that we have a normal size RV, a normal shape of the RV, so there's no dilation and eccentric position of the tricuspid annulus. There's no translation motion of the heart. It's a static position of the heart. There's no respiratory variation, and the scan plane is also very static and is not moving. And we all know from doing examinations in patients for tricuspid valve analysis that this is not true. Most of the time the RV is dilated or is in a different position. There's significant translation and respiratory motion, and you can't keep this plane static because it sometimes has to move. So therefore, but the guidelines in this sense give over these the three views that we defined for knowing the position and the nomenclature of the tricuspid. For example, upper left, you can see that we are seeing the mid-esophageal four-chamber view, which shows the septal and the posterior leaflet. Then we go on to the other view, which is the one on the right side, which shows the RV inflow and outflow. That's the anterior and the posterior leaflets. And when you go into the stomach, then you tend to see the the anterior and posterior leaflets. Now, one of the most important views and one of the most useful views is the RV transgastric short axis view or basal short axis view of the tricuspid valve. As you can see in this specific graphic, that we can not only see the posterior leaflet, which is more posterior in relation to the probe, then we are also seeing the septal leaflet, which is close to the interventricular septum, and we are also seeing at the same time the anterior leaflet, which is in relation right next to the aortic valve. So this is an important thing to know, that the nomenclature relates to their position to the rest of the cardiac structures. So example, anterior right next to the aortic, septal, which is right next to the septum, and the posterior scallop is right next to the posterior part of the heart. So that's an important differentiation that you need to know. And also this is very important, because knowing the basal short axis and seeing all three leaflets and their coaptation zone at the same time, we can identify the source of origin of the regurgitation, particularly in reference to when we are trying to do a percutaneous intervention to do an edge-to-edge repair of the tricuspid valve, or to do a percutaneous tricuspid valve replacement, which is also happening more frequently. So this view is one of the cardinal and the sentinel views, which is used to identify the various leaflets of the tricuspid valve during interventions. Now, throw into the mix, and that is the three-dimensional imaging, and particularly so simultaneous orthogonal plane imaging, which is we have a reference plane and a lateral plane that moves in relation to reference plane. Not only translates side to side, it sweeps, but also can rotate, and giving us a finite number of iterations of various parts of the tricuspid valve, and seen in two different orthogonal views. And I will show that in just about a second. And as you can see in this particular graphic on the right side, which is you see here right now in this specific graphic, you're looking at the basal short axis view of the tricuspid valve. And if you concentrate, it is this scan plane that is going through the tricuspid valve. Now, this, as you can see, is transecting the posterior leaflet over here and is going through the anterior leaflet. Now, this is the point of intersection of the tricuspid valve. Now, let's concentrate on this specific image. Now we know that the scan plane was transecting the posterior leaflet close to the back, and it is going through the anterior leaflet in the front. So this is somewhat confusing at times if you're not used to looking at it, but it has been found to be one of the most useful ways of seeing two leaflets at the same time. So this is another tact, another trick to identify and solve the quandary of nomenclature of the tricuspid valve when it is difficult to identify which specific scallop is the source of regurgitation or needs to be addressed or done something like that. So the challenge of the 2D examination, as we've briefly heard, is that these leaflets are thin and poorly echogenic. They have a complex coaptation zone. And in the midesophageal windows, you can see only two leaflets at any given moment in time. They have more than two papillary muscles. Of course, they are tricuspid valve. And then we do not account for the tricuspid annular motion and the translation motion of the heart when we are identifying the leaflets with the midesophageal windows when looking at the tricuspid valve. Now, the 3D examination of the tricuspid valve again goes through the same problems. As you can see that in this the 3D examination, you look in a non-FOS view through the right atrium, and you can see that the leaflets are again thin and poorly echogenic. The complex coaptation zone cannot be identified as well, and at the same time you can see that there are dropouts in this image, which are sometimes difficult to differentiate from holes or perforations or situations where you have to make a critical diagnosis whether this is the source of regurgitation or not. So going over the fact, and again the three-dimensional examination of the tricuspid valve is also hampered by the fact that there's no actual standardized display of the tricuspid valve. And what we are doing right now in these situations is that we are simply, identifying the leaflets in relation to the surrounding anatomical structures. For example, in the tricuspid valve, like I've reiterated in the past, is the aortic valve. The relationship of the leaflet to the aortic valve identifies that this is the anterior leaflet. The one that is related to the septum is the septal leaflet, and therefore the third one that remains is the posterior leaflet. Now, looking at this, the 3D examination, like I said in the past, a few slides, the most important part of the 3D examination is the multiplanar reformatting, and that consists of extracting an innumerable number of images from a three-dimensional volume set, and that's the most important thing that we have to look for and use as part of our armamentarium to identify the tricuspid leaflets. Now, I'll spend a little bit more time on this thing. As you can see that we are taking this image from a simulator to make this more obvious, and the more important part is to look at the red scan plane, the green scan plane, and I'll go over this one in a second. So, for example, in this specific graphic, you can see that the tricuspid valve is being shown with a green scan plane. We have a purple scan plane, and up top over here, we have the red scan plane. So now you can see, if you take this to a certain aspect, you can see that the green scan plane is going through, looking at the graphic, is going through the septal and the anterior leaflet. The red scan plane similarly is going through the anterior and the posterior leaflets based on what these scan planes are transecting at a given moment in time. And majority of the time when we are doing these interventions, we are looking at these three scan planes at the same time and guiding the interventionalist on where the edge-to-edge device needs to be positioned so that we can clip or repair the specific leaflets. And that's purely based on getting visual feedback from multiple images, and the presence of these multiplanar frames. The one on the right side you can see gives us this opportunity. For example, placing this being the anterior leaflet, this being the septal leaflet, this being the posterior leaflet, you can see, you can position based on these leaflets over here that where the edge-to-edge device needs to be positioned. And once you position the device in this specific frame, you can confirm the position based on the multiplanar frame. So essentially, you're looking at two orthogonal planes at the same time and trying to see whether the leaflet has been positioned correct, the device has been positioned correctly or not. So sorry, I'm going back. So keep going further. For example, now I'll make it still and put that in perspective. So as you can see, this is the aortic valve. So this is exactly the anterior leaflet. This is the posterior leaflet and the septal leaflet over here. So the green plane is going through the anterior leaflet right next to the aortic valve and the septal leaflet over here. This is the green plane going through, and you can see this in this specific cross section of the green plane that this is the anterior and septal leaflet. So if I want to position a device between the anterior and septal leaflet, I'll position this device looking at the basal short axis view that it is between the anterior and the septal leaflets, and then confirm this on the base of a visual feedback that whether this is exactly in that location. Now the red plane, you can see this being the aortic valve, this is the anterior leaflet, this across is the posterior leaflet. So the red plane is going through the anterior and posterior leaflet. So if you want to position a device, you have to position it in this view and then confirm in this specific view whether we are grasping the leaflets and we are exactly in the right location or not. So this is, you need to orient yourself looking at the same structure in different views to see whether this thing is being positioned accurately or not. So that's one of the ways of using three-dimensional imaging, not per se as the rendered image. For example, the one image that is particularly useless in looking at is this 3D image, because while this is a rendered augmented reality image, but particularly in an actual 3D examination of the mitral valve or the tricuspid valve, that doesn't help. More important is the extracted multiplanar frames that we get out of that 3D volume that help us in going to any further. So as you can see, this is again a live wide angle view. This is because we need to see all the leaflets, so therefore the most important thing over here is the sector size. So we tend to see the entire sector. We look at all the three leaflets. The one next to the aortic valve is the anterior, the septal, and the posterior leaflet, and this forms the basis of our identification of tricuspid leaflets during a three-dimensional examination. Now you're being shown in real time. In this one, as you can see that this is right on one edge is the short axis view of the tricuspid valve. The green and the red planes are being manipulated to demonstrate that which specific leaflets we are going through. We have the anterior leaflet, as you can see in this one. This basal short axis view essentially forms the basis of our recognition of the specific leaflets. For example, the green plane in this one is going through the septal and the anterior leaflet. So the green plane being seen over here, it was septal and anterior leaflet. Now it is going through the anterior leaflet and posterior leaflet, and now the green plane has been rotated to go through the septal and the anterior leaflet. So you can use this specific view as your view of reference, knowing which specific scallop is being transected by which specific scan plane, and then you can use this to your advantage while identifying the percutaneous intervention, or knowing specifically where the regurgitation is coming from, or is it amenable to any surgical intervention and what needs to be done. So this is something that needs to be done with practice, and once you're getting used to it, you tend to know that pretty well. So now we come to the more important, more controversial topic, and that's the tricuspid annulus. This is a little bit more complicated than the identification of the leaflets, but we'll try to again make it very simple. Now, here's the more important thing, that tricuspid annular dilation precedes emergence of tricuspid regurgitation, which means when the tricuspid annulus dilates before the patient has overt tricuspid regurgitation. Now, what that does is that, which implies that if we can catch and dilate an annulus prior to its irreversible remodeling when the tricuspid regurgitation happened, we can possibly salvage the tricuspid valve. So therefore, tricuspid annular dilation and remodeling is used as a surrogate of right ventricular remodeling, which means once the regurgitation happens, the annulus has already horribly remodeled or possibly not salvageable situation, and therefore we should be, there's no point in doing any tricuspid regurgitation at that, tricuspid repair anytime, because this is not going to help. So the real value of the quantification and analysis of tricuspid annulus is before the tricuspid regurgitation happens, or when the valve is salvageable and has not irreversibly remodeled. Now, here comes the most important thing, and that is that we tend to believe that tricuspid annulus is a distinct fibrous structure. Now, I'll take myself away and go over this slide a little bit more detail. And we think that it is a distinct fibrous structure because our assessment of tricuspid annulus is very mitral centric. We assume that it is a perfect circle, it is a uniform shape, and therefore also has a very uniform axis of dilation. So it's a predictable axis of dilation, and it's a circle, and is a very distinct fibrous structure. But now this is the important part, is to answer all these questions. That is it really a true fibrous annulus, or are we taking our assessment of mitral valve and applying it to the tricuspid valve assessment? Is it truly circular in structural structure? And which axis should we measure the diameter? And should we measure the axial diameters or the area of the tricuspid annulus? So this is a few of the questions that we'll answer in this question. So the first question to answer is this a true fibrous annulus? Now, I will go over particularly one of these best papers on the tricuspid anatomy. This is a state-of-the-art review about the anatomical and imaging considerations regarding the tricuspid valve repair using an annuloplasty approach. And this is the article where they argue this thing, which, if I move myself to this side, that it is underappreciated that tricuspid annulus is not a robust fibrous ring which suspends the leaflets. Anatomically, the fibrous tricuspid annulus is a distinct and incomplete, especially at the segment corresponding to the RV free wall. That's the most more mobile. and whereas the septal segment is less prone to dilation, and that's so-called the annulus is a hinge line of leaflets essentially, and not necessarily a fibrous structure. And if I go myself to again over here, and they have identified the tricuspid annulus or the lack of it, or the tricuspid orifice into multiple zones that relates to the the three leaflets. As you can see in this one right over here is the anterior, then we have the posterior, and then we have the septal leaflet over here, and the zones start with the margin of the tricuspid annulus, and they depend on the electrophysiological importance of where the bundle of His is and where we need to avoid during annuloplasty and stuff like that. At the same time, they have also identified that looking at an en-face view of the tricuspid valve, that the position where there's no fibrous structure, there's the AV node, particularly the region where the AV node crosses from the atrium to the left, to the left side, to the ventricular side, so that we can, for conduction of the, electrical impulse from sinoatrial node to the rest of the ventricle, and the bundle of His crosses through that. And that is particularly deficient in any fibrous structure, The next question to answer is it a real, true, perfect circle? This is from one of our papers where we went over the different studies which related to the assessment of the tricuspid annulus. As you can see, based on the ones that are, it has been seen for anywhere from being flat and pear-shaped, flat, ellipsoid, oval, non-planar, saddle shape, and changing diameter with functional tricuspid regurgitation. And really, if you get into the nitty-gritty of the way these studies were done, some were transthoracic, some were done on animals, some were not done dynamically. They were just end-systolic and end-diastolic frames. And there's a huge, they're not controlled for heart rate, particularly when you're doing three-dimensional imaging. So the differences in the appreciation of the tricuspid valve and shape could possibly be related to not the annulus itself, but the way we measured that, And if you look at it, this is again the graphic from the same paper where we are looking at the tricuspid annulus and using multiplanar reformatting, and we found that there is no exact axis of its maximal diameter, and it keeps changing, depending on how you look at it, in mid-systole, mid-diastole, and systole and diastole. And so this brings into the question that which axis or axial diameter should be measured, which represents the true axis of dynamism where the tricuspid annulus predictably dilates. So that's the question to answer. So if you look at in this graphic from one of our papers, that what we used was that we used took the septolateral dimension of the mid-esophageal four-chamber view, and also the AP view, that's the anteroposterior diameter, and then looked at the annulus. And you can see that both these, this thing is measured in a different axis. So this is the lateral dimension. And this being the septal dimension over here. This is the posterior. Up top over here is the posterior, and then we have the anterior, and this is the posterior. This is essentially looking at the right atrial opening, and when you look at it, and you can see that it is a pear-shaped structure. It is not a uniform circle, and the anteroposterior diameter appears to be longer than the septolateral dimension in tricuspid annulus, and it's not predictable, as you will see in the due course of time, that this is not the predictable axis of dilation as well. So now going over the annular shape and behavior. So just to go over the fact again that multiple 3D studies have investigated tricuspid annulus shape and dynamic behavior. They differ in methodology and subjects, mostly animal and transthoracic echo studies, and variations and differences in the definition of systole, diastole, whether it was done in mid-systole, diastole, and had varying frame rates and number of heart frames that were analyzed, because in 3D imaging is not controlled for heart rate. So it really depends on how many frames you have for analysis, and therefore it doesn't really matter. So it's possible to have differences, like I said in the beginning. It could possibly relate to difference in methodology and the subjects as opposed to an actual difference in the behavior of tricuspid annulus. And we also, and this study we did a planimetry and versus the derived area. If you were to take two axial diameters and then measure derive the area based on that principle, or if you were to simply go and get a projected area of the tricuspid annulus, as you can see in this specific graphic, that what we did in this study was that we measured the AP diameter in this study, and we measured the, if you go over here, is the septolateral dimension, and compared that to the area that was based on the MPRs and getting a projected 3D area of the tricuspid valve. So see, we tried to simply assess whether it was possible to correlate both these areas, and if being a perfect circle, two diameters would predictably give us the true area of the tricuspid annulus, and lo and behold, that was not the case. And what we found was that the tricuspid annulus shape is complex, with annular both high and low points, and annular area calculation based on linear 2 points, which is two axes, significantly overestimates the 3D planimetered area, which means projected area of the tricuspid annulus is smaller than these two diameters would predict in its own right. So that was demonstrated that you cannot use a single axis, just like LVOT diameter, that we've been using a single axial diameter, assuming that it is a perfect circle, underestimating the true area of the LVOT. This was a similar case that we were introducing a significant amount of error, assuming that this is a perfect circle. Now, as you can see in this specific graphic as well, that there are innumerable axes between the different points in the annulus, and you can have and area changes which depends on whichever axis you measure in this one. So it would be not prudent to use a single axial diameter of such an irregular structure to assume and predict or estimate the area of the whole annulus. So this is another one of our papers that we are actually very proud of, in which we took three-dimensional data sets of the tricuspid valve. We plotted different points of the annulus in end systole, end diastole, mid systole, and mid diastole. Put them in MATLAB to track the motion of the tricuspid annulus in the entire 3D space over the course of the cardiac cycle, to see whether or not there was a predictable axis of dilation, whether or not there was a specific quadrant of the tricuspid valve that dilated and was more dynamic than the other one. And that's what we call it, the tricuspid annular deconstruction and reconstruction. And what it was done was, as you can see in this specific, I'll take myself off and see that we were able to see, we took the tricuspid annulus in mid-systole and in diastole. And you see on this graphic on the right side, we plotted the points at the anteroposterior and septolateral direction, then rotated the annulus. The scan plane at multiple rotations got end systole and diastole, and also which led to us to be able in our ability to track the annulus in the entire cardiac cycle. And that was done by defining a plane of least fit square, which I'm not going to go into the detail. We got a centroid in the middle, and we're able to track different points and their relation to each other in the 3D space. So that was a kind of a very complicated, sophisticated analysis. And what we found was, in this situation, as you can see on the left, that we divided the tricuspid into multiple quadrants, which is the anteroseptal, the posteroseptal, the septolateral, and posterolateral. So this was to see whether or not the annulus changed its dimension in any particular quadrant. So because the axial diameters simply do not make sense, and we approached the analysis of tricuspid as though it was a sphincter more than an annulus. So does the area change at any specific quadrant than the other? And what we found was that the end diastolic to end systolic change was particularly in the anterolateral, which means across the free wall from the septum, was the greatest change. We actually even 3D printed tricuspid annulus, as you can see in this graphic, and put them in the exact shape on the same patient to see, was there any predictability in all these patients that we did that? So lo and behold, there was none. So this was a very sophisticated study to demonstrate that the lack of of a predictable behavior of the tricuspid valve when relates to axial change in diameters have a heterogeneous behavior in its quadrant changes, and we came to the conclusion that it was more prudent to measure the tricuspid annular area as opposed to a specific diameter. Then that brings into the question again which diameter should be measured, So this was again another one of our papers where we did a spatial and temporal analysis of normal tricuspid valve, and we reviewed studies done by different people, including a few of ours, which to demonstrate is there any predictability of the dilation of the tricuspid annulus. And lo and behold, again, like I said, based on your interactions of the way we interact with the 3D model, how many frames we have, what was the frame rate, and how did we define systole and diastole and in mid-systole, that doesn't really make any difference at all, and it was all over the place. So we took this approach to demonstrate the motion of the tricuspid valve in different, at end systole, mid-systole, end diastole, mid-diastole, and even 3D printed these models to demonstrate that how this thing changes. It's because that gives a little bit more spatial orientation to people when they look at it in 3D than trying to appreciate that in 2D. Again, we found that one of the most important thing what we found was that the area of changes particularly with the end diastolic area had the largest end diastolic stage of the cardiac cycle. They had the largest area of the tricuspid annulus, and this perimeter and annulus change was less pronounced in people who had functional tricuspid regurgitation. I'm not going to go into the detail how we found that, but we even tried to define in a 3D blender program, defining the motions of the various parts of the tricuspid annulus to show how it moves in the 3D space. As you can see, the lateral portion over here is the most mobile, and you can kind of appreciate the TAPC over here as well. So going over this tricuspid annulus, we took this a little further and defined a certain metrics of tricuspid analysis, which consists of looking at the annular area that changes, the perimeter, the non-planarity, the axial diameters, and right ventricular diameters that relate to tricuspid analysis. And what a measure that we defined over here was the tricuspid annular dynamism, and we defined dynamism as the percentage of area and perimeter change as a metric of dynamism, and that was calculated as end diastolic area minus end systolic area divided by the end diastolic area of the perimeter, and as a function of the percentage. So this was our definition of dynamism, and what we found in this one was that the annulus dilation was more in patients with functional tricuspid regurgitation. However, those FTR stands for functional tricuspid regurgitation, and NTR stands for patients with no tricuspid regurgitation. They found that there was a significantly more dynamism, which means it changes its area both in systole and diastole and acts more as a sphincter when there's no tricuspid regurgitation, as opposed to when the patient has tricuspid regurgitation. In this case, is when the percentage change of area as well as the percentage change in diameter dynamism was significantly less in patients with functional tricuspid regurgitation. So we tend to believe that this functional tricuspid regurgitation, the annular dynamism, can be used as a marker or a metric of the changes in the remodeling of the tricuspid annulus, and which can also be used as a surrogate marker of right ventricular remodeling as well. So what we found, and we have demonstrated in this one, is the conclusion was that a possible loss of annular dynamism and non-planarity can have the same predictive value for tricuspid annular remodeling as in the mitral annulus. So these results are intuitive, in that tricuspid annulus in functional tricuspid regurgitation seems to assume a passive non-sphincteric role during the cardiac cycle with progressive dilation and exhaustion of the coaptation reserve. So another article by Dr. Rebecca Hahn in Multimodality Image of the Tricuspid Annulus also touches upon this subject, demonstrating that the sphincteric contraction and excursion towards the right ventricular apex and is prevalent due to muscular structures of the mural annulus, which follows the contraction of ventricular and atrial cavity. So therefore, again, reinforcing this thing, that this is possibly a sphincter more than an annulus, and we may have been a little erroneous in our approach to the tricuspid valve, which was very mitral centric. So this concept of the dynamism was adopted by a few of the ultrasound companies. So this is software that is now commercially available, in the General Electric machines, the E95, where based on adequate frame rate, a 3D volume of the tricuspid valve can be automatically or semi-automatically tracked to demonstrate, if I go here and you can see, track the tricuspid annulus within its position in the tricuspid valve, and the dynamism and the change in area and the diameters can be automatically calculated, not just in a static and systolic and end-diastolic situation, but also as part of the entire cardiac cycle. So this concept of dynamism, changes in annular area, is becoming a little bit more prevalent, being more understood, and being more adopted. So in this context, this dynamic geometric tricuspid valve analysis is something which was considered more or less a bench technique, which means we were able to, we thought that this was only a research technique and we weren't able to do this thing. But now these techniques and these parameters are a few seconds and a few clicks away of a computer to get all these parameters, which include the septolateral dimension, AP dimension, the maximum diameter. So if it's a different diameter that is changing the most during cardiac cycle, the software automatically calculates that diameter changes in the planarity. But the most important part is over here, is looking at the dynamism, and that is the degree of change of the annular area from completely contracted to completely relaxed annulus, the most important ones. Now, artificial intelligence has also been extended to other aspects of it, which means now you can see that what we used to do as part of a manual tracking, manual identification, these softwares are available now that can track not only the tricuspid, mitral, and the aortic valve, but the entire RV and LV can be tracked at the same time to give you a complete and a global picture of how each valve interacts with the other. So in conclusion, tricuspid valve is part of a complex valvular apparatus. Annular remodeling is considered a surrogate of RV and valvular remodeling. 3D imaging adds value to the assessment of leaflets and annulus. However, at this time, tricuspid annular dimensions, which are as limited as they are in providing the information, are the mainstay of intraoperative assessment of tricuspid valve. And we now know that the 2D TE consistently underestimates the annular diameter which we measure in that time. And at the same time, looking at the complex analysis of tricuspid annulus, it displays complex spatial and temporal changes during cardiac cycle. Annular remodeling manifests itself as eccentric annular dilation. There's no predictable axis on which the annulus dilates. Changes in annular dynamism, which is the maximum area change in both systole and diastole, may be better representative of both annular and right ventricular remodeling, and could possibly be used as surrogates of the timing of surgical intervention in these patients. Thank you very much, and I hope you like this presentation. Good luck.